Professor Kogie Naidoo will talk about novel therapeutics and developments in the field of treatment of HIV. She also has 2 decades of experience in research in both HIV and tuberculosis.
A very good morning, good afternoon, and good evening, colleagues. I'm going to spend the next 10 to 12 minutes discussing innovations in HIV treatment as part of the symposium. My talk will cover innovations in both therapeutics as well as diagnostics and examine the suitability and scalability of these innovations to vulnerable populations in HIV endemic settings. We know that the currently available antiretroviral drug classes inhibit 1 of 4 steps within the HIV replication cycle. The innovations now include alternate drug classes that targets the HIV replication cycle. The nucleoside reverse transcriptase translocation inhibitors offer a first-in-class drug that is now undergoing clinical evaluation. Monoclonal antibodies that augment the immune response targeting HIV is also novel and offers an alternate therapeutic approach. REV, capsid, and maturation inhibitors work at the tail end of the HIV replication cycle. It is worth noting that we are now poised in an era of including long-acting injectables as part of our therapeutic strategy. There are many new agents that are long-acting products. These require less frequent administration, they're suitable for pre-existing multi-class resistance, and provide sustained viral suppression, all offering additional treatment options, especially for treatment-experienced people living with HIV. It is noteworthy that there is data on dual long-acting antiretroviral therapy use, so just 2 drugs instead of our traditional 3 or 4. The data from the FLAIR Atlas and the Atlas 2M study provides excellent safety and efficacy data for long-acting cabotegravir and long-acting rilpivirine that show non-inferiority to a 3-drug oral antiretroviral regimen in maintaining viral suppression. The new Merck product, islatravir, demonstrates viral suppression for more than 7 days with a single 0.5 milligram dose. These are currently being evaluated in clinical trials for the treatment of HIV in combination with doravirine. The current HIV therapeutics pipeline, so these are your innovative approaches, include drugs that are in various stages of regulatory approval. There are those that are indicated in a red box that are already have regulatory approval granted, and there are those that are undergoing clinical trial evaluation, either between phase 1 or phase 1 to 3. The broadly neutralizing antibody ibalizumab has already been approved for use in the treatment of HIV by the regulatory authority, the FDA. The other agents are undergoing various stages of approval with excellent efficacy and safety data that has been published in peer-reviewed journals. Much of the delay in the approval is the ability to fast-track the production to scale of many of these agents. So what are the implications of these novel therapeutic agents for vulnerable patients? It offers simplified ART, fewer drugs, fewer toxicities, and fewer drug interactions. The long-acting compounds enables less frequent dosing compared to traditional oral daily therapy. And it offers the hope of rescue treatment for patients with multi-class resistance. Both the several new drug classes as well as the broadly neutralizing antibodies both offer hope to those with pre-existing multi-class resistance. We're still unaware of the costs and resources that are associated with administering these novel products. We do not have sufficient cost-effectiveness data to show their suitability for resource-constrained settings. Some of these products do require cold chain, and it may hamper wide-scale implementation. We still have insufficient data from women, especially pregnant women and adolescents, and for co-treatment in patients with comorbidities such as tuberculosis. The injectables in high-burden settings may provide programmatic challenges such as long queues, congestion within health facilities, and additional considerations for needle safety. I'm now turning my attention to the innovations in the diagnostics available for managing HIV. Notably, the point-of-care early infant diagnosis offers huge hope in enabling same-day ART initiation in infants less than 18 months of age. We know that the standard of care approaches causes delay by up to 2 months or more in result return to caregiver and ART start. A point of care diagnostic, on the other hand, reduces the turnaround time to the ability to generate an HIV test result within 50 to 90 minutes, enabling same-day ART initiation. Looking at the innovations in these diagnostics, one can see a target product profile already generated by the WHO to help fast-track the delivery of these diagnostics to resource-constrained settings. We know that only 60% of HIV-exposed babies get an HIV test by 2 months from birth, and that the mortality by 24 months is up to 52%. Early infant diagnosis combined with linkage to care and early ART initiation will help reduce infant mortality. We know that systematic reviews conducted on point-of-care testing have already been published and provide compelling data to suggest a drastically reduced time to result return to caregivers, where same-day result was provided in up to 97% of cases. And in 6 out of 7 studies, 75% of patients that were diagnosed HIV positive using a point-of-care technology was able to initiate ART within 2 days. Now turning our attention to point-of-care viral load testing for ART efficacy monitoring. We know that a point-of-care viral load test result will help us manage HIV and reduce the turnaround time for a viral load test result. It reduces the costs associated with repeat visits to healthcare facility and the delay to clinical action. And same-day results were able to be provided in 99% of all instances. In this study by Paul Drain and colleagues, a point-of-care viral load testing that was combined with nurse-based care, task shifting using enrolled nurses, improved both viral suppression and retention in care. Furthermore, there was an improvement in switching to second-line ART and maintaining viral suppression amongst those on first-line therapy. There was also enhanced referral of stable patients to community ART centers for decentralized care. So in short, point-of-care testing simplified HIV treatment and management in HIV-infected individuals living in endemic resource limited settings. The implications of the novel diagnostics for vulnerable populations are clearly it would simplify both diagnosis and treatment. It will enhance diagnosis of infants and enhance linkage to care. Earlier treatment initiation and switch can be initiated, especially in failing patients. It helps minimizes retention losses and costs from multiple health facility visits. And very importantly, the likelihood of a clinical action is far stronger with a point-of-care test than it is with a lab-based test. And it will help with decentralization of testing and other services. On the other hand, some of the disadvantages would be the need for increased training of health personnel to be able to both implement, to perform, as well as to interpret the results of the test. It will lengthen health visits and would result in long queues and congestion in health facilities due to limited test throughput. The problem is the repurposing of lab infrastructure or facility infrastructure for point-of-care testing may have an adverse effect on other programs that rely on those tests. For example, gene expert-based point-of-care viral load test may have an adverse impact and may cannibalize the TB program, taking away much-needed resources from the TB program to supplement the HIV management program. And we don't yet have enough data on the costs and cost effectiveness of such a strategy. So to summarize, we now, I've discussed with you the innovations in HIV management, including both the diagnostic and new drug innovations. And these new drug innovations include both new individual drugs as well as new whole classes. These innovations hold a promise of a very bright and exciting era in HIV treatment, especially as we have millions of patients that are no longer eligible for NNRTI therapy, and those that are that have multi-class resistance. This now offers hope for a new strategy. So we still do not have enough data on the impact of these interventions on treatment outcomes in both treatment naive and experienced patients in disease endemic settings. To optimize both new diagnostics and drugs, we need to identify those who would most likely benefit from these strategies. We need to identify where to locate these services, both the new drugs and the new diagnostic. Does it occur at a central point within the frontline facilities? Does it get located within a secondary or a tertiary service? What triage system would be most appropriate in order to maximize use of these innovations? And how do we deliver and integrate these innovations? How do we implement them within busy healthcare settings? The empiric data guiding implementation, notably both cost effectiveness, access, who the suitable patients are, and what are the suitable provider criteria and advocacy is still required. The innovations collectively carry enormous potential to simplify and enhance chronic HIV care. Thank you for your attention.